About 11:02, so we're going to go ahead and get started with the webinar. Katie, you're good to go ahead and start recording. So good morning, everyone, and thank you for joining us today on this Friday morning. My name is Amy Prentice, and I'm the State Government Relations Manager for the National Psoriasis Foundation. For those of you that aren't familiar with NPF, we are a nonprofit organization whose mission it is to cure psoriatic disease and improve the lives of those affected. So our purpose here today is to discuss step therapy and patient protections that were recently passed this year in West Virginia after the governor signing HB 2300. So before we begin, I want to take a moment to thank our bill sponsor, Delegate John Kelly, and his various co-sponsors, and of course a coalition of patient and provider groups that were on the ground, that were supporting this legislation along the way and really helped to get across the finish line. So as we have this conversation, if you have any questions, feel free to submit those in the chat box in your webinar control panel. And we will also be recording this webinar, and we'll be sending it to all participants, which you are more than welcome to share. So I am happy to introduce you now to our panelists today. We have Dr. Wasim Saikali, who is a practicing rheumatologist at the Rheumatology and Pulmonary Clinic in Berkeley, West Virginia, who has been in practice for more than 20 years. Dr. Saikali is a member of the American College of Rheumatology, American College of Physicians, and the Arthritis Foundation West Virginia chapter, among various other societies. He has a few disclosures today that he has been a speaker for Celgene, which he received an honorarium, a speaker and participated in clinical trials for Pfizer, which he received an honorarium in PI, and was involved in clinical trials for J&J, for which he received a PI. And we also have with us today Ashley Kenneth, who works for the National Multiple Sclerosis Society as the Senior Manager of Advocacy. In this role, Ashley advances the Society's advocacy initiatives in various state legislatures with a focus on Maryland, Virginia, and West Virginia. She is responsible for policy development and volunteer engagement that drives change for people living with and affected by MS. And Ashley and I do not have disclosures at this time. So this webinar is applicable for CME credits. The NPF is accredited with the Accreditation Council of Continuing Medical Education to provide continuing medical education for physicians, and this is worth a half credit. Okay, next slide. So I thought before we really got into the specifics of HB 2300 and what it actually does, I thought it would be good to take a moment to have a refresher on what step therapy actually is. So step therapy is a utilization management tool by health insurers that requires a patient to first try and fail on 2 or more medications before granting coverage for that original treatment prescribed by their physician. We are seeing step therapy being used more and more frequently. In 2010, nearly 60% of commercial insurers were using step therapy. In 2013, 75% of large employers reported offering plans that utilize step therapy protocols. And I think it's important to note there that that 75% figure, obviously being in 2013, was 4 years ago, which I know if we saw figures as of today, it would be much higher than that. We're seeing this happen often on a regular basis. So insurers claim that step therapy helps lower healthcare costs, which obviously is a very big issue these days. Healthcare costs is talked about constantly. And while saving costs, they claim that it maintains or possibly improves care quality. But we know that patients are not uniform, and that in some cases, step therapy really has the opposite effect and can really cause more harm than good. we talk about healthcare costs and the use of step therapy, there's really one study that we like to point to, which was on spending on schizophrenia medication in Georgia Medicaid. What that showed that with step therapy, the state did save over $19 per member per month. But however, those savings were accompanied with a $31.59 per member per month increase in expenditures for outpatient services. When patients aren't treating their condition or their disease effectively, we know that that has some negative health outcomes, which of course in turn leads to patients going back to their doctor or in worst case ending up in the ER or the hospital. And we also see statistics that, you know, when patients are faced with these really complicated step therapy protocols, that sometimes they just choose not to treat at all, which can obviously have some really negative health impacts. One other statistic before we kind of wrap up our discussion on what step therapy is, in California over a span of about 10 years, they reviewed how often these types of decisions by insurers were overturned. So in California, the independent medical review of benefit decisions like step therapy, 64% of insured decisions were overturned, and only 28% of those insurance company decisions were upheld. So that shows, you know, the need for this legislation, that, you know, when these independent medical review board looks at these protocols, that in the end they decide they're really not in the best interest for their patient, which really shows the need for legislation such as this. Okay, next slide. So with that, I'm going to go ahead and pass it along to Ashley, who is going to go into an in-depth review of what HB 2300 does.
Great, thank you, Amy. So House Bill 2300 was passed into law by the West Virginia State Legislature during the 2017 regular legislative session. As Amy mentioned, the bill was sponsored by Delegate John Kelly with support from Delegates Ellington, Summers, Chris Wagner, Ward, Atkinson, and Rohrbach. In fact, this is the second time that Delegate Kelly carried this bill. He introduced the same legislation last year in 2016, and the bill was actually passed by the legislature, but somehow the wrong version of the legislation was signed by the governor, and thus the bill became null and void. So we came back this year with a new bill, and patient advocacy organizations such as the National MS Society, the Arthritis Foundation, and the National Psoriasis Foundation worked at the grassroots level, meeting with legislators, sending emails, and sharing stories to demonstrate to our delegates and senators the critical importance of having access to the most appropriate medication as prescribed by one's clinician. We are so pleased that the bill is passed once again, and the bill officially becomes law this month, which is 90 days from passage, but it will apply to health benefit plans that are issued or renewed after January 1, 2018. To be clear, this law will only apply to health plans that are state regulated, which includes fully insured plans and the state employee health plan. There are efforts currently at the federal level to address this issue with self-insured plans. Legislation has been introduced, but that effort is really just starting to get underway, so stay tuned for more information on that. So what does House Bill 2300 do? It establishes a uniform process for clinicians to apply for an exception to a step therapy or fail first requirement. In other words, it creates a path that allows physicians and other clinicians to ask a health insurance company to approve a drug that is different from what the company wants the patient to take first. Furthermore, it makes that process transparent and accessible. The language explaining how a clinician can apply for the exception should be easy to understand and accessible on each carrier's website. But at the core, this new law is about the patient. It ensures that West Virginians have access to the medication that will work best for them as approved by their doctor or practitioner. You can go to the next slide, Katie. This legislation establishes a criteria that health plans must adhere to when reviewing a step therapy exception request. There is a list of 5 exceptions for which a step therapy override must be granted. This is essentially a set of reasons that a carrier must allow a clinician to prescribe a medication that is different from what they would typically require as a first-line therapy. All exceptions are listed on the slide in front of you, and I'll go through them quickly. First, an exception must be granted if the required drug will likely cause an adverse reaction by physical or mental harm. I heard a story once of a woman who was newly diagnosed with MS, and she also had a very severe needle phobia. Her insurance carrier required that her first therapy for her MS be an injection. Her clinician, of course, appealed that decision, but it was denied, and it was even recommended by the health plan that the patient go to therapy for her phobia before taking an oral medication for her MS. Stories like that just seem absurd to me as a patient advocate and highlight why legislation such as HB 2300 is so important. Also, if a person takes numerous other medications, perhaps some management drugs, and the drug in question would cause a harmful interaction, of course an override should be granted without delay. Second, an exception must be granted if the step therapy drug is expected to be ineffective based on known physical or mental characteristics of the patient and their prescription drug regimen. For example, a person who drives a truck for a living, and it may not make sense for them to be on a medication that makes them drowsy for much of the day. Third, an exception must be granted if a patient has already tried the step therapy drug or another drug in the same pharmacologic class, and the drug just simply didn't work for the patient or cause an adverse event. Fourth, an exception must be granted if the drug prescribed by the clinician is in the best interest of the client based on medical appropriateness. And lastly, an exception must be granted if the patient is already stable on the drug prescribed by their healthcare provider. Quite frankly, it doesn't make sense to take someone off of their medication if they're on one that's working for them, simply to try a cheaper medication that may or may not be less effective. A key provision of this law is that a health plan or a utilization review organization must provide a prescription drug for treatment of the medical condition at least until the exception determination is made. This is critically important for patients, especially for people with MS. It's recommended that after an MS diagnosis, a person begins treatment as soon as possible. And this provision ensures that there will not be a lag in treatment. It also ensures continuity of care for patients who may already be on a medication that works for them. And with that, I will turn the call back over to Amy.
All right, great. Thank you so much, Ashley. I know myself and, of course, our patients are extremely excited to have these into law and available for them to use. So we're going to switch over now to the provider perspective on this legislation. Dr. Cycli, I was hoping you could take a minute first to talk about your experience with step therapy and how it affects not only your practice, but the treatment of patients.
Thank you. Again, I'm a rheumatologist here in Beckley, West Virginia, and for the last several years, this bill is way overdue. It's becoming a challenge. The last 2-3 years, we probably have hired 2 extra staff in my office just for simply approving an authorization process that's becoming redundant. And most of the time, we have to get the approval through 2-step therapies, and even the step therapy is not as easy as what the insurance makes you feel. We still have to fill forms, we still get denial, and sometimes we have to arrange with some health provider, whether it's a physician, medical director, nurse, to justify why are we asking for this drug to start with. So I'm pretty sure I'm talking on behalf of rheumatologists because we have this problem all over, but dermatologists will have it and any primary care physician will have the same issue. It's taking time consuming. We have, maybe 5 years ago, I have a part-timer doing the authorization. Now I have 2 full-timer medical assistants. Just their job is to fill forms and go through the hurdles that are put on physicians to just get the approval. So it is becoming very difficult, and I'm glad we can use that. A lot of physicians know that even a simple anti-inflammatory in any primary care setting, if you feel like one drug is superior to the other or safer to the patient, the insurance will tell you to try all the generic that are available on that formulary before they even approve one medication. For example, celecoxib, Celrex, is generic now, And up till now, certain insurances will not pay for it until you try every single generic. And you know that might be safer. All NSAID has similar GI toxicity, cardiovascular. But for example, I like to use this medication if somebody is on blood thinner, for example. I get denial after denial after denial. And the same with the biologics. Again, these exceptions are valid. A lot of patients, I just heard Ashley saying about that patient that needlephobic. I have a lot of those in my office. It is very difficult to get an insurance to pay for an oral treatment for psoriatic arthritis or for rheumatoid arthritis, such as tofacitinib, like Xeljanz, or again, we have apremilast for psoriatic arthritis, Otezla. These medications, sometimes like needlephobic, yes, but that's only one aspect. For example, my patient with congestive heart failure, anti-TNF, regardless of the preferred, are contraindicated. And some, when I call or send the authorization denied, you have to do the preferred etanercept or other medication. And when we tell them there is congestive heart failure, will send us a record from the cardiologist. The cardiologist might be out of state. They moved out to this area. We have to collect information that's pure waste of time just to document to the insurance the patient has congestive heart failure. Please approve drug A or drug B instead of the other one. Patient with TB positive, they were treated before. Every physician knows that certain medications are safer than the anti-TNF for TB. Good luck getting that medication without talking to a medical director and sending records and fax and send us from the health department. You gave them treatment for TB and all stuff. So it's more hassle issue. It's more denial. And sometimes when somebody fails a drug, for example, I'm glad I saw that, failed miserably on one mechanism of action, for example, anti-TNF, regardless of the drug. You don't have to go through the list to just justify jumping to a different mechanism of action because it's not on the formulary. But this is what we do every day. Just because patients, we know they need this medication, we do letters, we do faxes, we get records, we get old records just to say that they failed. They ask you on the form months and years that they tried the preferred drugs. Well, if they moved out of the area, I don't have the records. But they insist, we will not give you anything until you tell us they failed. So all these hassle that we see in our practice has led, hopefully, to this successful bill. And we still don't know exactly how it's going to work. Is it going to be a one form for all insurances? It is going to make it easier on my office and all offices to get those preferred medication that, in my judgment, are safer to my patient. So I can give you more examples, but basically, hopefully you have questions regarding these issues. I have different scenarios. Patients with multiple sclerosis, they can take anti-TNF, regardless if they're preferred. I need to use other mechanism of action. So all these hopefully will help physicians to navigate those complex system insurance that are forced on physicians just to get the preferred medication because they think it is cheaper. Thank you.
Okay, great. Thank you so much for that. And, unfortunately, this is the same points are made not only, from doctors in the rheumatology space, but really from all specialties. And, hopefully in practice, once, we start getting a really good system in place for this exception to step therapy protocols, that it will, help preserve that doctor-patient relationship, really leave those decisions, of course, in your hands, and ideally save you a lot of time from arguing with, those insurers and medical directors. I think, once this becomes common practice, hopefully this bill can be used preemptively, and we won't have to go into this really long, drawn-out process of exceptions, and we see step therapy become used less often with these protections in place. So, Ashley kind of mentioned, I think briefly, that, West Virginia is not breaking ground here. Thankfully, we've seen a lot of other states pass similar legislation. So I'm going to go back to Ashley briefly and let her talk a little bit about the national landscape and what efforts states are doing to pass similar legislation. Ashley?
Sure, thanks, Amy. So the National MS Society has been tracking this issue across the country. In 2017, 11 states had introduced legislation regarding step therapy reform. And so far, that legislation has passed in 4 of those states: Colorado, Iowa, Texas, and of course, West Virginia. And I've seen varying numbers, but the total number of states who have step therapy reform or an expedited and transparent process for applying for an exception is around 15. In Virginia, advocates there are gearing up for round 3. 2 previous bills failed in that state, and new legislation is expected to be introduced in 2018. So I expect that we'll continue to see legislation introduced in several states in the coming years. And honestly, West Virginia's law is one that patient advocates look to as an example across the country. Then, of course, as I mentioned previously, there's a federal law. It's H.R. 2077. And that bill's just really starting to get off the ground. But if that passes, it would apply to all of the self-insured plans, not just the state-level, fully insured state health plans.
Great, thank you so much for that. So I'm going to call attention as we start to wrap up here to our last slide. And this is the contact information for the West Virginia Department of Insurance. Sometimes when these processes are put into place, there's questions, or maybe an insurer staff is not familiar with these exception processes. If you're having any trouble, whether that be as a patient or a provider, you can always refer back to these slides. They will be sent to you later, that has a hyperlink for appeals, as well as a direct phone number and email there. So now I'm going to go ahead and check our chat box. If anyone has any questions, go ahead and feel free to type them now. Okay, seeing none. Ashley, we were actually talking about this earlier. I know Dr. Cycli mentioned whether we will see a uniform form for step therapy exemption from insurers on their websites and what we expect these to look like. You know, unfortunately, that's not clarified in this legislation, so we're not really sure. But there is something being proposed next year, a standardized prior authorization form that Ashley informed me about. So I don't know if you wanted to provide any details there, Ashley.
Sure. So last year, another bill was introduced simultaneously with this one that would have created prior authorization reform, including establishing a standard form for all health carriers to use to approve, just to expedite and make a more clear and transparent process for prior authorization. There are other provisions in there, such as a set turnaround time. So you are not waiting for weeks or months for approval, but days. And so that bill was carried by Senator Burns. It did not get a hearing, so it did not move last session. So a group of patient advocacy organizations are coming together this summer to decide how to move forward with reintroducing that bill next session and hopefully getting a hearing and moving it forward. But obviously, if a standard prior authorization form was established, it would certainly help with the step therapy process as well, and just make it much easier for clinicians to apply to have their patients use the medications that they deem most necessary.
Absolutely. So thank you again. And if anyone has any, would like more information on these step therapy laws throughout the nation, please feel free to look at steptherapyinfo.com. That has a map that will be available to look at what's going around the nation and what these bills actually look like. So that brings us to the conclusion of our webinar. Again, I wanted to thank all you for being here and our panelists for taking time out of Friday morning to talk about this important issue. If you would like any more information, I would offer you to get in touch with me, whether you want details on the bill, to stay updated on future efforts, or would like to get involved in West Virginia or any other state. You can email myself or Ashley. You can have my email once we send out, obviously, the link to the webinar, and I'll make sure to include Ashley's email as well. This, as I said, will be recorded and it'll be housed on NPF's website. But again, you'll get in a link via email. When we close out your webinar, you will be prompted for a survey. So I ask that you help us improve these webinars going forward by taking a few minutes time to fill out that webinar. So again, thank you everyone for being here, and that concludes our educational webinar on step therapy. Have a great weekend.
Thank you.
Thank you.